My dad was a doctor. I used to be in his clinic all the time. I got into anesthesia. It's very, very difficult because obviously it's very, very competitive. The clock starts ticking, and within the first 2 years, you've got to attempt your primary exams. You fail 2 attempts within that first 2 years, you're out of the program.
A close friend of yours tragically took his own life during the anesthesia specialist training.
So once he failed the exam for the second time, and obviously was told that he had to exit the program. Then he resorted to, obviously, the easiest way to kill herself was with worse signs. The stresses of anesthesia as a whole specialty, consultants have even committed suicide as well.
That's in the US. About 300 to 400 physicians die by suicide.
If you mention it, like you sort of red marked or benchmarked at, or this person has got mental issues. Like, I don't want to go through this. There is life outside of anesthesia.
Join Disruptive Doctors.
I'm Dr. Selina, your host and co-founder of Disruptive Doctors. At Disruptive Doctors, we're building a platform to help doctors like you impact healthcare differently. In Postcall, we dive into the untold stories of doctors who are breaking the mold, trailblazers who are redefining what it means to be a doctor. This is Postcall Beyond the White Coat. Hi, welcome to another episode of Postcall Beyond the White Coat. Today, I'm speaking with our guest, Dr. Shaun Nicholas, a doctor whose career has taken him from the intense world of anesthesia training in Australia to the corporate halls of the pharmaceutical industry. We'll be diving deep into Dr. Shaun's personal and professional experiences, including a heartbreaking loss of a close friend during training and his current role at AstraZeneca. Hi, Dr. Shaun.
Hi, Selina. How are you?
Great. Thanks for joining us today.
Thank you so much for having me.
Whose idea was it to do medicine?
Actually, my dad was a doctor. So obviously I was around the environment on a day-to-day basis. He was a GP. So I used to be in his clinic all the time. So it was sort of instilled in me from a very young age.
Were you intrigued by what he was doing?
Sort of. I mean, I was always science inclined during my school days. I knew what I didn't like. I'm the kind of person. So obviously, him being a GP, I used to always grow up studying in a clinic. So I used to see all the cases which came in, including the bleeding cases, etc. So then, obviously, from a very young age, I got more and more intrigued. And and the medicine was my pathway after that.
Okay, so let's start with your time in Australia. You studied in Australia and you started working as a doctor in Australia. You never worked in Malaysia at all. So what was it like working as a doctor there? I think a lot of doctors are curious, especially Malaysians and those that have not worked in Australia. They're very curious about what is a working life like of a doctor in Australia. Was it everything you imagined when you first entered the working space there?
All right. So I'll start off with so obviously medicine is 6 years, and then your 6th year of medicine is actually pre-internship. So there's no exams in your 6th year. So your 6th year of medicine actually gives you an idea of what interns, or in Malaysia, you all say housemans, go through on a day-to-day basis. So you get different rotations. And then obviously after you graduate after 6 years, and then you start your housemanship. So housemanship, I will just be brief. You only have 4 core rotations. So you go through your core rotations of surgical, medical, emergency, and a rotation of your choice. So for me, I pretty much was more surgically inclined. I didn't quite like medical-based stuff. So then it's very subspecialized. So where you do, so my surgical rotation was breast and endocrine, colorectal, and then my medical rotation was respiratory, and then you end off with emergency medicine. So it's very subspecialized compared to what doctors in Malaysia go through, like your 9 different postings, as I recall, for 2 years of housemanship here. And in terms of how housemanship is like there, obviously the stress levels are different from what doctors in Malaysia go through. But I'll be very honest, like the longest shift that you do as a houseman is roughly 13 hours when you're doing your long calls, especially during your medical or surgical rotations. But it's very much guided as a houseman. You're a clerk and you're doing everything. You don't get the much hands-on experience that doctors in Malaysia do. And you're pretty much a clerk in that sense. But you get to do your main gel course, etc. I think you'll say Granula in Malaysia. And then from there, you get an incline on what you actually like and all that. So the work-life balance is not too bad as a houseman, because it's only 1 year. So yeah.
Okay, so was it everything you expected? Because see here, when I first started before I went into medical school, actually, like there's a lot of things you'd hear from seniors or people who were doctors, they'll say that you will never get to sleep, you're gonna be on call all the time. So what was it? Was there any unexpected challenges when you got into housemanship in Australia, or
I
was it
think to
what
be
you
on
expected?
to be honest, I was looking forward to, more hands-on stuff. Like I'm the kind of person where I like hands-on, I like equipment-based stuff. So you don't get that much opportunity as a houseman. Obviously, what I really enjoyed most was emergency medicine. And, there are days where you work 4 shifts. It depends on which hospital they put at. So obviously the bigger hospitals are quite busy where you get, the influx of patients where you're on a 10-hour emergency shift. And then you can see close to, 30, 40 patients in that shift. But obviously, housemanship as a whole, I think it's a molding factor for me where obviously there's not much hands-on experience, but then it is so subspecialized on the rotations you do. It actually gives the housemans a chance to actually deep dive into those specific rotations, and then gives you a broader picture on what you actually want to do once you enter your first RMO year or MO year as such. So my overall first year as a houseman, I would say it wasn't very stressful. You get to learn a lot of stuff, especially coming from medicine into housemanship or internship, as what we call it. You can sort of apply what you learn. There's not much application-based stuff. The doctors struggle when they enter housemanship and all that. So it gives you that 1 year exposure to actually apply what you've learned. And then that is a stepping stone to what you sort of want to diverse or specialize in after.
How did you know that you wanted to dive deep and specialize in anesthesia?
Oh, so actually, anesthesia wasn't my first calling. So actually, I was very, in my 5th year of medicine, I actually had a rotation in cardiology. So I really, really like cardio a lot. But what put me off cardio, or what I mentioned is the long process of training in Australia, where, MRCP is what you call it in Malaysia. In Australia, you go to basic physician training. So that's 3 years of internal medicine. And then to start specialize, you may not necessarily get cardiology because it's so intense to get into advanced training like cardio, nephro, neuro, etc. So that immediately put me off. And then with my final rotation in housemanship or internship, I really like emergency medicine and I really like resus a lot. So then I sort of knew, all right, it was either ED, ICU, or NS. And then I knew I liked acute medicine. So then in my MO year, I really thought that, all right, let's get a shot in getting a rotation as anesthesia MO in my 2nd year as a doctor.
Okay, so was that how you developed this interest of anesthesia?
Yeah. So from 6th year itself, I had a 3-week rotation in anesthesia and I really, really enjoyed it. I really liked, how patients can come in and then you can give them the best possible pain care and best possible experience when they undergo any form of surgery and all that. And I liked that concept of where you come in, I fix you, you go. So then obviously I was very inclined to get a rotation as an MO in my 2nd year. And it's obviously very, very, very competitive, especially for anesthesia, ICU. Just let you know as well, anesthesia and ICU is 2 separate programs compared to what it is in Malaysia. And I also really liked how anesthesia was very equipment-based, very hands-on. So you get to deal with, intubations, you get to deal with resus, you get to deal with your machines, etc. So, and obviously your different kinds of drugs as well. So that really, really intrigued me. And obviously I love pharmacology as well.
So, like, how does because earlier you mentioned that anesthesia and ICU is completely different. In Malaysia, it's merged as one. So,
Yes.
how is it different in Australia?
So the ICU program is its own individual pathway program. So it's 5 years of training as well. So those who want to become an intensivist, you can go through your ICU pathway. And there is a merge with anesthesia where you come over, the intensivists in training come over and do 1 year of training in anesthesia. Whereas once you're in the anesthesia training program, it's a 5-year training program as well, including a fellowship year. And you only do 6 months of ICU training in that whole year. So pretty much think of it as, everything happens in theater, and then after the case, being a complex case, you just hand over the patient to ICU. So the care ends there, only theater based.
Was there any particular incident that made you decide, okay, I know for a fact anesthesia is for me?
I think it goes back to one of my night shifts in emergency medicine, because obviously you get to do a lot of resus and intubation. And we had this patient came in, because obviously drugs is a big issue in Australia. So with a lady came in who came in with GHB or juice overdose, where she was completely apneic or not breathing. And I got to be part of the resus as a MO as well. And I got the chance to do my first intubation, obviously with the registrar on my side. And that was my stepping stone. I'm like, oh wow, this is really, really interesting, like the whole resus space environment. And so that was my my first sort of calling into where I wanted to go. It was either ED or anesthesia, either one I was a bit happy with. And then obviously I can tell you the process of how I got into anesthesia after that.
Okay, how did you you got into the anesthesia training program? Was it difficult? What was the training like?
All right, it's very, very difficult because obviously it's very, very competitive. So how they sort of benchmark candidates is obviously based on you getting the 3-month rotation as an RMO in your second year or your third year. Some MOs are not lucky enough to get that 3 months in anesthesia, so you don't get that hands-on experience or that visibility from the consultants for them to know that you're interested. Going back to how hard is it to apply for training is very, very difficult. So it's all state-based application. So obviously there's South Australia, Western Australia, etc. And they go based on your CV or whether you've done any rotations in anesthesia, whether you've had any experience as a service registrar. And the interview is obviously, you can apply. And I only got a chance at an interview on my 4th attempt. So you can see how difficult it is. But the main bit is you need to get that rotation as a MO, and that is a stepping stone to getting your crit care year, etc. Like what happened to me.
So if you don't get that rotation, you cannot apply. Is that what it is?
No, so there's no point applying because your chances are like 0 to none. Because you have to do, after your housemanship, you need to write a cover letter to the director of anesthesia or ICU to get that 3 month rotation where there would only be 8 spots. So think of it as 4 rotations as an MO, 1 hospital. If you're covering 2 hospitals, it means there's 8 spots. So if it's 1 hospital, it's 4 spots. Means only 4 candidates will get that spot for that year, for that 3 months. So if it's 4 different rotations, then that's 12 spots per se, or 16 spots. So it's very, very difficult.
So do you have to apply every year?
Yeah, Australia is every year as an MO, you have to apply. So you have to apply and do the interview. I mean, it's quite straightforward. You will get the position again. But that is where you sort of decide, all right, after your first year of housemanship, you do your interview to be an MO. And then after that, you apply every year. And then if you want to get a surgical year, or if you want to get ED year, or you want to get an ICU year, then that is based on how your first year is and how your consultants look at you, etc.
You attempted to get in for 4 years.
So I attempted to get in for 1, 2, 3 years. So after my first rotation as an MO, towards the end of my second year as an MO, I tried to apply, and I was declined. And then I was lucky enough in my third year to get a crit care year. So a crit care year where my director said, all right, it's half anesthesia, half ED. So where during ED, I was like the airway person. And then obviously that full year of purely anesthesia and ED gave me a stronger chance to apply. And even in that year, during my anesthesia rotation, I'm applying because there's 2 attempts a year to the program. So I didn't get in. So there's 1, 2, 3 attempts I didn't get in.
So how many people are you actually fighting with for a spot?
Oh, it's hard to say, Selina. I would say per intake, there's roughly around 5 people who get in for the whole of the state. So be like to say the whole of Western Australia or the whole of New South Wales, there's roughly around 5 to 6. Each state is a bit different. So you're competing with not just your hospital, but everyone else from the other hospitals. But just to let you know, there's actually 2 sort of pathways to do anesthesia in Australia. So there's the official training program, which is where you're in the official college, so Franska. And then that is where you enter and you do your 5 years, and then they rotate you state-wise. Another option is where you get a service registrar position, means you get a 1 year as a service registrar, and you're in the training, but in that 1 year, you get to obviously apply to the college because you're already doing 1 year of anesthesia, and you log in your cases, you do your logbook, etc., and that counts towards your training. But eventually, you want to get back into the official training because the issue is once you come towards your 4th year of anesthesia, once you pass your primary exams, the 6 months pediatric anesthesia rotations are given to only the official training candidates. So there are even fellows who have completed 5 years of training, done their exams, without having done 6 months of fellowship, 6 months of pediatric anesthesia, and they can't come out as a consultant, which has happened to someone I know as well.
Wow. So what happens to them then? Do they have to go into the training?
They just have to wait till they get that 6 months of peace. So normally it's women who go on maternity leave and then the position pops up and then they get a slot. So what I got in is, so I was lucky enough after my 3rd year as a crit care MO, my 4th year was actually getting in as an anesthetics service registrar. So that means you're in the official pathway. But obviously I was doing anesthesia for 2 years before that already.
Okay, so you've mentioned previously the training itself is incredibly grueling. Can you paint a picture of what it's like and what were the moments where it really pushed you to your limits?
I think, going back to the shift work per se in anesthesia, I would say it's like your normal 8 to 5 kind of hours. Your on-calls are only 12 hours if you either cover 8 to 8 or you're on pain service covering APS or you're on night shifts doing an 8 to 8 shift. So there's nothing more than 12 hours. So, but then obviously the complexity of whether you're running, you've done anesthesia as well, Selina, so you would know the complexity of running emerge theater, sections, etc. So it's quite taxing based on which hospital you're at. That's one aspect of things. But the main aspect is how stringent the college is or how stringent the training is once you get into the program, once you start your service registrar training and start doing your logbooks, it's like a ticking time bomb. Means your clock starts ticking, and within the first 2 years, you've got to attempt your primary exams. As you know, obviously, you've got your primary exams, your first exams in anesthesia, and then your exit fellowship exams. So the stress was actually very much the primary exams. I can go in depth if you want me to. So
yeah, explain what do you mean by that? Like, does it mean that not everyone sits for the exam at the same time? You have to decide if you're going to take the exam or not going to take the exam. What do you mean by that?
So there are 2 attempts per year for the primary exam. So your primary exam consists of 2 parts. So obviously, actually 3 parts. The first part is your MCQ based questions, and then you got your short answer questions, and you've got to pass those 2 papers first before you get invited for the viva. All right. So then you get that. So once you pass your viva, you've passed your primary exams. And why I said it's stressful is because firstly, it's a 75% fail rate for the primary exams. So they kick off a lot of candidates at the start because the exit exams are quite straightforward and it's more clinical based, whereas the primary exams are very much science based. After that, they only give you 2 attempts. So after 2 attempts, so think of it as 2 lives. After 2 lives, you're pretty much done.
What do you mean by that?
So if you say you fail the first time, you get to repeat it again, but you have to repeat it within that 2 years. You cannot be doing just say, I've done my first year as a registrar, I've done my second year as a registrar, I can't attempt in my 3rd year. In that, so just say you attempt it within the first year, then you fail. So you only have 6 months when the exam slot comes in again to attempt it for the second time. And then you fail the second time, then your 2 years is up. So you fail 2 attempts within that first 2 years. And then pretty much that's it. You're out of the program.
So you're out of the program and you can't be a specialist anymore? Or is there other ways to attempt to become a specialist?
I don't know how things have changed now. Back then, if you're not in the official France card training program, you get pretty much, means if just say you're a service registrar, means you got a spot in a hospital, in that hospital as an anesthetics registrar, you get 3 or 4 attempts, as I recall. Sorry, I just can't remember right now, but the official attempts are 2. So pretty much there are people who have done it 3, 4 times, and then once your lifespan is up, then they kick you out of the training program. And yeah, you can't attempt it anymore.
Oh, so it sounds like you have to time your exams, you have to study, and you have to work.
Yes.
When you say the passing rate is 75%, does it mean
The
failure rate is 75%? Sorry. So does that mean that they will remove 75% of each cohort?
I don't know how it works, but pretty much for each attempt at the exam, so there's 2 attempts per year. So just say if it's, 10 people who are attempting to sit, roughly like, so what 75% fail rate. So only 3 or 4 will pass in that sense. But just to give you another perspective, which is even more stressful. So there are even few people I know who have passed the MCQ, passed the short answer, gone to attempt the Viva, failed the Viva, and you've got to reattempt everything again, which is insane, like absolutely insane. Like you've passed the MCQ, you've passed the short answer, which is the hardest portion. You just have to go for the OSCEs or the Viva, and then you fail the Viva, and then they make you reattempt the MCQ and the short answer again. And then that's one life done. Yeah.
What is like the mental state of all this? I mean, yourself and your cohort classmates, what is the mental state of you guys at that time during this whole process?
I think everyone is different, so I cannot speak I'll speak for myself per se. So obviously the stresses of going through theatre every day, going through different kinds of bosses you got different kinds of consultants on the way they drill you, etc. That's one stress of going to work as well. Another stress of the exams is insane because you got to find time in between your shifts to study or during your case as well to study because of like, let's put it this way, you are even afraid to register to attempt the exam because once you register, this is all right, the one life is coming up. So that's the mental state of like, oh shit, I've got to, go through this daily text in my head of registering to know that, all right, if anything goes wrong, this is my one attempt done.
How did you handle those kind of stresses, and did it take an emotional toll on you?
I'm the kind of person where I'm very good. I'm very carefree, very, very, very lucky going, but obviously I think a turning point for me came where I do what I do quite well, etc. I know I can study, but I think the bigger stresses for me were getting drilled in theatre by my bosses. So the thought of going to work, and I know I'm being different from Malaysian doctors, get this every day, so I can't speak to what y'all go through. I'm just speaking on my experience as a doctor there. Going in for a 2-hour, 3-hour case, and you know that the consultant is going to drill you and open a book and say, all right, let's discuss this now. And you're so tired after a shift, you haven't gone back home to study, and then that whole day is just you getting drilled about physiology or about your gases or about your physics in your etc. So that scared me even more.
I think that scares everyone. I mean, it happens here as well, getting scolded. But did you feel that it was right thing for them to do where they are actually grilling you every day on your knowledge and pushing you to the limit?
I think it stems from them knowing how difficult the primary exams are. So the reason they do it, not everyone does it there. What don't get me wrong, there have been some amazing consultants I've worked with who are really, really nice. Australia in general, the culture, the consultants are very, very nice. You get that 1-2 fellas from overseas who may not be nice, and that's just the way it is. It's mainly the doctors who come from overseas. The normal doctors there are quite nice, actually. But it stems from that main problem, which is how stressful the exams are, and them knowing that, all right, you only have 2 attempts or 2 lives at these primary exams. Once you pass your primary exam, that's it. You're gonna finish anesthesia. So I think, yes, I felt that they had to do it in some sense because they had to sort of test your knowledge to a certain extent. But I felt in another ways, this is your only chance in, learning as much clinical hands-on experience in theatre on that stress-free basis, and improving yourself in anesthesia. So there are days where, like for me, if I'm rostered with the same consultant 3 days in a row, who has drilled me the first day, I'm mentally not prepared to go to work on the second or third day, but I know that I'm going to get drilled again. And that just ruins my whole, in that sense.
Okay, so you lost a close friend. A close friend of yours tragically took his own life during the anesthesia specialist training. Let's talk about that. How did that? What happened, and how has that affected you?
I'll just give you the overall perspective. So basically, as you know, what anesthesia is one of the most stressful specialties in the world, or the exams as well. So suicide rate is very much kept under key in Australia around this. But yeah, there have been cases all around Australia, but this happened to a friend of mine. So what happened was, so obviously the mental stresses of going through the exams is one thing, and then failing for 2 attempts and being kicked out of the official training program is another thing. So once he failed the exam for the second time, and obviously was told that, he had to exit the program and can't be a registrar anymore, then he resorted to, obviously, the easiest way to kill herself was because we got access to all our drugs. And obviously it was a shock to us, to everyone as well. But I felt that the college has not done much to overcome this issue. I don't know how things are now. So obviously I've left Australia a while ago. But that took a toll on me, because you worked around this colleague on a day-to-day basis. You do everything together as well. You study for the exams together, and seeing that your close friend break down or go through that moment all because of an exam, it was very, very difficult for a lot of us per se, because then you put into perspective of you going through it yourself, and what happens when, because the odds are very much not in your favor. What happens once you hit that 2 failed attempts, and then you go through that whole mental stress of knowing that, you can't continue with anesthesia, and this has been your only pathway in medicine after housemanship.
I mean, were there any signs that this could have happened?
To be honest, a lot of those cases, I won't go in depth. You don't see it coming, because it normally happens once you fail the second time. And there were signs where you see them again, they come to hospital, they're not themselves and everything, and you try your best to be there for them, etc. But when it happens, I mean, we've had, a consultant commit suicide, as what I've heard as well, in Australia, in anesthesia as well. These are not just trainees undergoing exams, but the stresses of anesthesia as a whole specialty, consultants have even committed suicide as well. So that whole high-strung environment in anesthesia, where on a day-to-day basis, you got difficult cases, you got, your trainees, your college, etc. So the whole environment doesn't play a positive impact on the mental fortitude of a lot of people, and some people are not mentally strong enough to overcome that.
Yeah, I think that's the big elephant in the room, physician suicide, because I saw stats on the American College of Emergency Physician. These are stats in the US. About 300 to 400 physicians die by suicide. And I couldn't find stats anywhere else. But there are many, many stories of this. Like in Malaysia, recently, at the time of this recording, there was a pathologist who died by suicide. This recently, August 2024. And then prior to that, we've got 2 other housemen or trainee doctors who have taken their own lives. I mean, it happens, it seems to be happening around the world. What are your thoughts on this? Do you think they are isolated cases, or is there more that's something missing, that's something that we are missing out on?
I think, coming from my perspective, in anesthesia per se, I can't speak much about Malaysia, but I think overall the stresses, I can speak about the profession per se, the stresses of being a doctor, the stresses put on us from, our families, because, obviously we come from the Asian background, there's only medicine, or, lawyer, engineer, etc. So that's one aspect. And then once you enter the profession, you're seeing all your different colleagues specialize or enter different clinical pathways per se. So there are ongoing stresses even from medical school. And this is all pent up and built all towards the training. And especially I see what you guys have gone through in Malaysia as well. My friends are all doctors here. I see what they go through on a day-to-day basis when they speak to me. So I think it's kept under the rug because it's easy to just say, now, he's stressed with work, etc. But there's more to that on what this person is going through as well. And a lot of times the college or, the hospital per se does not take enough initiative to, voice out and speak to these people to actually see what they're going through and how they can overcome it. Because as you know, mental health is a growing thing all around the world, as you just mentioned, and let alone our profession as a doctor is even more stressful. So I think not much has been done to help doctors who go through mental stresses or to go through depression, to help them in any way possible.
Yeah, I actually do agree. Like, I do that. I actually also lost a colleague. He took his own life as well. There wasn't much awareness about it after that? I mean, he had a posting in anesthesia, so he knew what to do. He was going through some rough patch and no one saw it coming, and it just happened. I mean, he booked himself into a hotel and he took his life, and colleagues from the hospital had to go and identify him. So that was it's a really, really sad situation, thinking about it, like how alone we all may have felt, and there was no outlet for this and nowhere to share. And physician suicide is such a hush hush. Like I said, the only stats that were available were in the US. But
Sure.
what about Australia? What about Malaysia? Malaysia, we're not even talking about it.
I mean, exactly. In Malaysia, it's just, you don't even hear about it. You guys go through the insane stresses at work with your, like 36-hour on calls as an MO, and, the difficulties into specializing. And it's sort of like a taboo topic. Like, you cannot even mention it. Like, if you mention it, like, you sort of red marked or benchmarked at, or this person has got mental issues, which I feel it's absolutely ridiculous, because it needs to be addressed. It really, really needs to.
So how has this whole incident with your friend and you needing to reflect on, because you guys were studying together, doing cases together, working together. How did this whole incident change your view of your training and your path?
I think it sort of made me see the bigger picture that, I didn't want to go through the stresses of anesthesia per se anymore. And it sort of opened up my picture that, that there is life outside of medicine. If medicine was not my only pathway. And if anesthesia wasn't my pathway, obviously I was mentally strong enough to say, okay, look here, if I can't do anesthesia, there's always GP training. There's always other forms of specialties to go. So I think for me, I had that mental fortitude and the mental strength to actually pull myself out of a toxic environment per se, and say that there are different options. But as you know as well, Selina, I came back to Malaysia for other reasons as well, which I can mention a bit later on. So, but I think for me, my key factor was, or my key changing point was, having that light bulb flicker in my head and say, look here, like, I don't want to go through this. I don't put myself through these stresses anymore, and that there is life outside of anesthesia.
What was this where, I mean, did this incident force you to take a break, like pull a hard break and say, okay, let's evaluate, is this the way forward or am I going to change things?
I did actually, like, I just took time for myself as well, did a bit of locum, etc. My dad's got a clinic in Malaysia, and obviously, COVID happened and I couldn't come back home. And a lot of other things happened in my life as well, which made me make that big decision to come back to Malaysia. So obviously, I realized that I had to take time for myself and sort of see the big picture before moving forward with my next decision.
Okay, so what made you decide, okay, this is it, I am definitely not going down this path anymore and it's time to leave anesthesia and move on to something else?
I'll say there's a two-pronged approach to this. I think firstly is, my mom was diagnosed with CA pancreas. So that was another additional stress in my life as well. My dad passed away from CA pancreas. So it was only my mom and my brother left. So that was one factor that made me realize that I wanted to leave Australia and come back home. And obviously another factor was, like I mentioned early on, the stresses that I felt on a day-to-day basis, and the stresses of studying for the exams or even attempting the exams. I didn't even attempt the exams. I went through, a few months, and then I realized that now this is not for me. So two of these put together as well was the big stepping stone in me saying that, all right, this is done. This is enough for me. And I want something else. I want a different kind of opportunity, or beat whatever. So that made me realize that, I still like my dad's clinic in Malaysia. If I ever wanted to come back, I still did a bit of locum work, etc. So then I stepped out and sort of managed my dad's clinic from a business perspective. But obviously COVID was happening, and I did that with my brother before I finally decided to come back to Malaysia.
Okay, so like when you decide to leave your training and to do something else, do you feel any stigma or judgment when you decided, okay, I'm going to step away from this path? Was there any judgment from your peers? Did you go through some sort of emotional turmoil?
To be honest, I'll be very frank and honest. Things are seen a bit differently in Australia in that sense. I don't know how things are in Malaysia. So you don't get the stigma that you all go through here in Malaysia per se. But in Australia, they sort of respect your decision on what you want to do, etc. Obviously, when you're in training, it's very stressful. But in the end, if you know that this is not for you, you want to try something else, they're very much open and sort of giving you that sense on what you want to do. And it's just obviously there's so many candidates who want to apply, so they know that they can get the next person in really fast. So it's just a matter of, there's no stigma. I'll be very honest. There are different stresses in different specialties, be it surgical, be it anesthesia. But, if you ever want to leave and go in something else, people don't see you differently in a sense.
What about from family members?
So in Australia, there's only myself there. So my brother was back home, my mom was back home. So in the end, thinking from my family, they're very much open. It's just my mom and my brother back then. So whatever decision I made, there was no stigma from them. I'm very lucky that I had a very supportive family who, even like my dad, when he was around, he didn't force me to do medicine. It was my decision in the end. So I didn't have that strict upbringing in that sense where you have to do this, you have to specialize, or you have to do this per se. So even around my family, my brother, for example, they were very supportive in my decision, and whatever I did as well, they were always going to be supportive for me.
So, walk us through your steps. Like the moment you decided, okay, I'm going to step away from a training program, like what next? What was your thought process there?
I would say pretty much because obviously I came, let's just say where I came back to Malaysia, my dad's clinic was still running, right? So obviously I took that year to figure out after I left anesthesia what to do. I did a bit of locum, and then obviously I came back home. I'm from Malacca, so my dad's clinic was still running. So I sort of managed that clinic and took some time off just to see how things were, etc. So that was one step. And then another step was me actually figuring out that, all right, I think that there is life outside of medicine. Like I have all this knowledge I have left, but what can I do with what I've learned as a doctor for all these years? And that is when I started, Googling stuff, reading up more on different articles to see what next venture I can get in. But by then I was already back home running my dad's clinic before things went a bit south with that. And I had to decide, all right, I have to get into something.
Okay, so what did you Google?
Well, what did I do? Oh, I can't even remember actually that. I sort of knew that pharmaceutical took in a lot of doctors per se. So obviously I was Googling jobs in pharmaceutical on what doctors can do. I never knew that they were hiring doctors per se. And then I was Googling stuff in medical devices to see whether they took in people in medical devices, etc. That's one aspect. And then obviously I have a lot of friends who are doctors back home in Malaysia as well. So I was asking them if they knew anyone who had lab medicine. And then I had one friend who told me, oh yeah, you can enter the insurance line as well. So there's this heap of influx of words coming into me from friends, family, etc. on, what I can do. But obviously, I think in my mind, I was fixated on pharmaceutical from very early on. I don't know why. It was just something fixated. It was just in my mind per se. I was not a businessman. So managing my dad's clinic was not something I was very good at. My brother was better at that. So then that is when I started reading up more about pharmaceutical in general. And then I'm like, oh, so there is life in pharmaceutical as a doctor. I never knew that. So yeah.
Before we continue, I want to share something very special for our doctors who are listening. If you're a doctor and considering a career shift but don't know where to start, Disruptive Doctors offers a non-clinical Pathfinder workshop. This workshop is designed to help doctors like you explore new opportunities beyond clinical practice and how to choose the right path for you. Whether you're still unsure of whether you should leave medicine or ready to make a change, this workshop is tailored for you. So do check out our annual Disruptive Doctors Conference that happens every August, where like-minded doctors like you come together, share ideas, and impact healthcare differently. So before we get into pharmaceutical, you mentioned you were managing your dad's clinic. What was that experience like?
This was obviously like during COVID per se. So it was not much, it's just more sort of managing the books, the stock of stuff, etc. We had a doctor working there, but it sort of gave me the bigger perspective to learn a bit of business. My brother is a finance person, so I was learning a lot from him. But it gave me the idea on looking at how my dad actually ran a clinic, So from a business perspective, from the nurses to the accounts to the drugs coming in, it gave me it opened up my mind broadly on, the business acumen side of things in managing a clinic for for a year.
Okay, because mostly doctors will never get that sort of experience. Did that help you with getting your job in pharmaceutical?
I wouldn't, nah. I would say what helped me was before I joined AZ. I can go into that as well if you want me to.
Yeah. So how did you like? What did you do next? I mean, I know you didn't
Okay, so
get
let's,
your job the first time
yeah,
round, right? So
correct.
what did you do?
So I came back to Malaysia, around July 2021, and I started just Googling jobs on JobStreet. I use JobStreet a lot. I mean, I was obviously new. I knew what I didn't want to do. So I knew I didn't want to be a doctor in Malaysia. So I knew what my friends had been through, knew what you've been through in a sense. So I'm like, not, never. I don't even have my APC or my MMA registration, just so you know. So I started Googling stuff on JobStreet. I got my CV updated over what I did in my years in Australia and obviously managing my dad's clinic. Sort of just applied for pretty much anything science related. So I applied for all forms of pharmaceuticals. I applied for devices. I applied for sales position, science based, because I knew that my strengths were science related. So I just kept Googling and applying like 30, 40 applications on JobStreet on day to day.
And what was the first job you landed?
So then I was very lucky enough that within 1 month of me being back home, after COVID, etc., when the borders reopened, because obviously the borders were shut and reopened. So I did an interview with a Singaporean-based medical device company called Catalyst. So they were a distributor in Singapore, but they opened up shop in Malaysia. So it was for a clinical executive role, and what they were doing was actually a device which was the world's first non-invasive intragastric balloon for weight loss. So I was very much intrigued because obviously I knew this was in the lines of bariatric surgery and obesity. But then when I interviewed then only, I got a picture that, all right, it's a bit more clinical stuff where, sorry, I have to go in depth, if you want me to. Or, yeah. So it was a clinical executive role where you sort of need to know the device, explain the device to doctors as well. And then comes the sales perspective of it as well, which that shocked me later on. But yeah, but that was my first job within 1 month after I came back home.
Why did the sales part shock you?
I hate sales, to be honest. I'm not a sales, I'm not a salesperson. I did well in sales, surprisingly. I mean, so think of it as I was very lucky that they gave me a job immediately. And because they wanted a doctor who speak clinically to upper GI surgeons, to bariatric surgeons about the device. But then obviously the stresses came where it was the B2B, B2C approach. Means your B2B is your business to business approach, and then you got your customers who are calling in to find out about these procedures and trying to close the sales, etc. So I didn't like the daily cold calls to customers and saying to explain the procedure, where you can do it, Gleneagles or Sunway, etc. Which hospital to do it with. So sales was never my strong forte, but the clinical stuff I enjoyed. So I enjoyed explaining or teaching doctors how to use the device because it's completely non-invasive, means no surgical, no anesthesia, no endoscopy. I enjoyed proctoring them when they did the procedure, and I enjoyed reading up on all the stuff because it's an American-based device. So yeah.
Okay, then how many attempts before you finally landed in pharma?
So 4. Fifth. So 4 attempts, then fifth. So my fourth attempt was together with it with AZ. Yeah. So 4 attempts.
What do you think was the biggest challenge for you to transition from clinical into non-clinical?
I think the biggest challenge was how to explain it. That as a doctor, you're sort of with like a one directional approach. Means you're a treating physician. You come in, your patients come in and you fix them per se with whatever they come in with. And to venture into a non-clinical part was to actually how do you utilize your knowledge and apply that in a non-clinical setting, be it a medical device company or be it a pharmaceutical company. And that was the difficult part for me because I was so used to anesthesia, for example, where you come, I fix you, you go, and then moving out and that whole different approach to understanding business acumen, understanding how sales work, understanding the different aspects of a business. So that really, I found it quite difficult, especially in my first company.
Do you feel like you were leaving a part of your identity as a doctor behind?
In certain ways, yes, because like for all these years, I was only known for doing that. And I felt that, that was my calling, to do 6 years of medicine, specialize, be a doctor, like, people in my family, etc. So yes, I felt that, don't get me wrong, there are days where I do miss anesthesia. I do miss what I did. And because it will always be in you in a sense, because it's what you've gone through. Yes, when in my first job back home in Malaysia, in a Singapore-based company, I missed it a lot. And that is where I still felt that I was not happy in that first job still. 'Cause I felt that there was something lacking.
Could you put a finger on what it was?
So what was lacking was I felt that I was not utilized enough as a doctor. So I needed more science-based approach stuff. And that was why I still kept applying for pharmaceutical, even while I was in that company, because I knew it's very difficult for doctors to get in pharmaceutical because, they want people with experience. But so that's why I still kept applying. And I knew that the science-based stuff in pharmaceutical was what I wanted to be doing, because I felt that, all right, I'm in this med device company. It's more of a sales-based approach, because from a clinical executive, I went over to a brand manager. So I was dealing with, marketing and breast implants, which was the biggest assets back then. And I even hated that even more. I don't like marketing. So I felt that all my years as a doctor, the knowledge was not being used well or utilized well.
Okay, so now that when you were in pharma, was it difficult? I mean, I understand there was a challenge from clinical to non-clinical, but then from your previous role in a medical device company and now you're in pharmaceutical, what was the challenge like?
The challenge was, I mean, I'm in AstraZeneca. So the challenge was actually how fast MNCs are. So it's a very fast-paced organization as well. There are a lot of different processes. There are a lot of different working in a bigger team. So in my first company, it was a very small team of 5 of us. And now you've got, your huge sales team, huge marketing team, different cross-functional teams. So that was like a culture shock the moment I came in my first 1 month. It was honestly a big culture shock where I had to gather as much in the first 1 month and just get the ball rolling and start running, because in MNC, you know how things are. It's just day in, day out, day in, day out. So that was my big struggle, adapting from a smaller base company to a big MNC.
Okay, so did you ever, at that moment, did you started doubting leaving clinical practice, or you were like, okay, no, this is it, and there's no turning back?
I think I'm the kind of person, Selina, where I adapt very well. I think my friends can say about this. So one of my key strengths is adaptability. So I told myself that like I never gave up in interviewing. I interviewed 4 times to enter pharmaceutical. So I persevered very hard. So I told myself, all right, I'm in. You just gotta do it, Shaun. There's no other way. You just gotta learn, adapt, and do. And I just put my head down and just got.
What do you think were the key skills that you had from your clinical practice that you brought on with you into pharmaceutical?
I think the biggest asset that a doctor can bring to pharmaceutical is your strong scientific acumen. So obviously, when you enter pharmaceutical in medical affairs, science is our basis. Obviously, there's different therapy areas as well. So my biggest strength that I brought in was my strong scientific knowledge. That's one thing. And another thing which I felt that the strengths I had as well from clinical work is sort of working under pressure. Because as doctors, especially in anesthesia, you're used to resus, you're used to that stressful environments. So how well you handle stresses is another important thing that I brought in as well. So I think my 2 biggest things is the knowledge aspect of being a doctor and the stuff around medicine, and obviously handling stresses.
Okay, so now that you're in the pharmaceutical industry, how do you feel that is different from clinical practice, and how are you impacting healthcare differently?
I would say it's a completely different approach. So as a clinician, you're treating, you're the frontline person in treating patients, in, using your skills to the best advantage possible. Whereas in pharmaceutical, we are making an impact on the overall of healthcare with our different drugs and molecules. And not only that, like what I feel that I've learned along the way in my 2 years in AZ is how you change, how you work together in different means, from the government perspective, from working with doctors to changing policies and changing the whole paradigm or ecosystem as a healthcare perspective. As a company, that is what I felt that you're giving back to patients in a bigger way. So even though I'm not treating patients as a clinician now, I'm still helping patients in a bigger perspective with our drugs, with our molecules, and with the changes we're doing as a pharmaceutical company.
Was it something that you had to get used to? Because, I struggled for a long time also because I was so used to fixing patients on the spot and then sending them off. Was that something that you had to get used to?
I think because I had that long transition, so I think that gap when I joined my device company for a year before I ventured into AZ, because I went away for a while, so not much I would say, because like I said, I adapt very very fast. So you throw me in this environment, I'll adapt. You throw me as a salesperson, I adapted. You throw me in marketing, I adapted. So I would say that my skills, my strong skills, were I adapted very very fast. So I would say not really. I got used to it quite fast, but I give credit to actually learning a lot in my first company in Malaysia. Because that actually, because of this small base company, you're learning business acumen, you're learning soft skills that helped me to get into pharmaceutical. So that was a huge, huge stepping stone. And going back to your initial question on what helped me as well, wasn't so much. I mean, yes, I'm a doctor and I had my years of experience as a clinician, but also that small base company, learning business acumen, doing sales, understanding the business per se, and how things are run in terms of events, agendas, etc., helped me in my interview as well, or helped me in getting in.
Okay, so what's your advice for doctors who were, in the crossroads, whether they should continue clinical, they still love practicing, or should they go into non-clinical? Like, what would your advice be for them?
I would say, I mean, each person is different, so you have to go with your calling. So, what is your calling? So, I knew what my calling was very early on when I decided to leave anesthesia and come back home for my family. But so my first, my only advice to them is don't just rush into something for the sake of rushing in. I know the stresses which is happening with our healthcare in Malaysia now and doctors in KKM, etc. But have an end goal in mind. So for me, I knew my end goal was pharmaceutical, but how long it took me to get there was a while. So if you know what you want to do, you know that your strengths are in this, then by all means go for it, and learn the skills that you need to learn to enter whatever you want to do. But look at the bigger picture of things, that that there's so many different ventures you can enter as a doc. I mean, using your MBBS or as a doctor to enter what you want based on your strengths. So just don't jump into something immediately for the sake of jumping in.
How long did it take you before you got to where you want to be, which is pharma?
So from the time I left till I got it, I would say 2 years, Selina, 2 years. 2 years. So it took me that, I mean, I never gave up. So when I came back home, I applied for pharma. I never got in. So I can say that the pharma, I won't go into the names of the pharma I applied to. I'm in AZ now. But it took me roughly 2 years. But what I did was I told myself that, all right, I am entering pharmaceutical. I want to be in pharmaceutical. I want to be in medical affairs, because it sort of, I had that bond with it in that sense. So the more I read about it, the more I kept up to date with stuff. I felt that I connected with it. I can't explain how, but I felt that, all right, this is what I want to do. This is what I can foresee myself doing. So, but yeah, in the long run, it took me 4 failed attempts at 4 pharma interviews, 1 year in a med device company undergoing sales to marketing, and that taught me a lot of things which I use now in my role in pharmaceutical as well. Because obviously, when you're in pharmaceutical, you're not just in medical affairs. You're having a cross-functional collaboration with sales, with commercial, with marketing.
What did you have to pick up along the way so that you could land this job?
Okay, so I would say the things that I had to pick up along the way was my interviewing skills. I'm very nervous as a person. I speak very fast, as you can see now. The main thing that was different in medicine was my anesthesia interview was 15 minutes. You go in there, they ask you case-based stuff, etc. Whereas the interviews to enter any company, even my Mac device company, was a 2-stage interview, whereas in pharmaceutical, it's a 3-stage interview. So I had to pick up interviewing skills, I had to pick up communication skills, and I had to pick up PowerPoint skills.
Wow. Okay. So 3 stages. What were the 3 stages like?
So basically, med affairs. So the first stage of the process is obviously they give you a clinical paper. So obviously, in medical affairs, there are different therapy areas. So I was applying for oncology, so they gave me a clinical paper, which is a New England Journal of Medicine paper, based on one of the drugs in our therapy area. So you know what a clinical paper is like. So you got to it's given to you maybe 3 to 4 days before the interview, in a sense, and you've got to dissect that paper and then present the paper during your interview. And the paper can be from 12 to 16 pages, but obviously going into your abstract, your primary endpoint, your secondary endpoint, etc. So that's one aspect of the first interview. And then the second aspect of the interview is obviously all the questions based on why you're in the pharmaceutical, etc.
Okay. So what's your advice for those doctors who want to get into pharma?
So my advice is obviously really, really brush up on 3 key things, I would say. Firstly is your interviewing skills. A lot of times, I would say for me as well, doctors don't interview that well when they want to enter pharmaceutical. They just don't have that knack of talking, etc. Secondly is really, really brush up on your scientific knowledge. Because when you come in and you present, just say, on heart failure, for example, you're going to be asked questions on heart failure. It's things that you know as a doctor. So put in that effort before the interview to actually read up around the disease area. A lot of times people have come in and they don't bother reading up. So what's the point then? Thirdly is actually really, really the biggest part of thing is understanding what a scientific paper is, because this is going to be a bread and butter moving forward once you enter as an MSL. And understanding how to dissect a paper, understanding what that whole paper really means. And this means reading up different journals, doing journal clubs. If you're still in medicine, doing journal clubs in a hospital, or just reading up more papers to actually understand what a scientific paper solely is.
Okay, well, if you've enjoyed this episode, don't forget to subscribe. That wraps up another episode of Postcall. If you're thinking of transitioning, check out our non-clinical Pathfinder workshop and also our annual conference that happens every August, where like-minded doctors come together to share ideas and impact healthcare differently. Until then, I'm Dr. Selina. Take care and keep disrupting the norm.
Join disruptive doctors. Oh, disruptive doctors.